Ladies and gentlemen, for the next 15 minutes, Jörg Halter and me want to introduce our approach in treatment of chronic graft-versus-host disease. I have some conflicts of interest to declare. None of them should influence my talk. The first thing, if you need to treat chronic graft-versus-host disease, is to make sure that you're treating, in fact, chronic graft-versus-host disease. So you need to first make the distinction from acute graft-versus-host disease, which would then require treatment for acute. And you all know that this requires the presence of at least one diagnostic sign of chronic graft-versus-host disease or a distinctive manifestation, but keep in mind that distinctive manifestation do not prove that you in fact treat chronic graft-versus-host disease, and if there's no diagnostic sign present, and especially if your treatment fails, you may consider an histological confirmation of your diagnosis. And you, of course, need to exclude other diagnoses. For instance, leukoplakia could be carcinoma of the oral mucosa. Lung infection could mimic obstructive lung disease, BOS after transplant, and so on. The classification of chronic graft-versus-host disease makes that distinction between acute and chronic, with overlap being a form of chronic graft-versus-host disease. Acute graft-versus-host disease, as already mentioned, needs to be treated as acute, independent of time. And you need to keep in mind that graft-versus-host disease is a dynamic process, so you can even have acute after chronic graft-versus-host disease. First thing, if you think about chronic graft-versus-host disease, you need to keep in mind that this is not an homogeneous disease in terms of prognosis. And also, of course, in terms of organ distribution, and patients, for instance, having lung graft-versus-host disease or liver involvement with elevated bilirubin or GI involvement have a far worse outcome than those who have chest, skin, eye, and oral disease, independent of severity. The next issue is if you have a patient directly progressing from acute into chronic graft-versus-host disease, the prognosis is much worse, and this is a situation where you simply are in a second-line situation already at first line. And then another easy-to-assess biomarker of risk for treatment-related mortality is the presence of low platelets at time of diagnosis of chronic graft-versus-host disease. And given the organ distribution and the risk factors, it's almost automatically clear that one size fits all does not apply in treatment of chronic graft-versus-host disease. What are the modulating factors if you choose to treat? The modulating factors are immunosuppression at time of onset of graft-versus-host disease, and a time interval between end of immunosuppression and onset of symptoms of chronic graft-versus-host disease. Are there any risk factors present? Is there a lung involvement with a lower FEV1? Is there an elevated bilirubin present? Has the patient diarrhea, low platelets, a progressive onset, or is fragile? And of course, the relapse risk also has an influence on the decision. So mild chronic graft-versus-host disease usually requires topical treatment or low-dose steroids. But keep in mind, some patients do not benefit from graft-versus leukemia effect, and those patients may be already treated with systemic immunosuppression at the first sign of chronic graft-versus-host disease. Low-risk, moderate graft-versus-host disease with a long time interval between stop of immunosuppression would probably benefit from steroids only, most within a dose range from 0.5 milligram per kilogram to 1 milligram per kilogram per day. High-risk patients either defined by short intervals as in stop of immunosuppression or high-risk organ involvement, low platelets, would probably benefit most from a combination treatment involving a CNI or possibly an mTOR inhibitor or ECP, or for both substances, only phase 2 trials are available. What are these indications for second-line treatment once first-line treatment failed? So you need to treat at least for 2 weeks with an an adequate dose of steroids to make sure that your treatment failed. A stable disease after 4 to 8 weeks would require a switch of treatment, or the inability to taper below 0.5 milligram per kilogram per day prednisone would be also an indication to start second-line treatment. And of course, there is one rare indication that is intolerance to first-line treatment. The patient who is totally intolerant to corticosteroids. So response assessment for second-line treatment needs to be performed within a time range from 2 to 6 months. What are the triggers to change your treatment in skin if the kind of involvement changes with new superficial or deep sclerosis or progression with an above 25% body surface, or a stable inflammation on treatment longer than 2 months. Eyes, if there's an upgrade by 1 grade according to the NIH organ grading, then you first need to optimize your topical treatment. If this fails, you need to escalate your systemic treatment. And oral graft-versus-host disease, the same applies. Try to first optimize topical treatment, and if this fails, change the systemic. And in lung GVHD disease, a drop of the FEV1 more than 10% should trigger a new treatment line. What are the factors influencing your decisions in second-line treatment? First of all, the relapse risk. If you have a patient with high relapse risk, you should avoid over-immunosuppression with a substance known to increase the relapse risk, which applies for CNI and MMF. The infectious disease history, some agents have come along with a higher risk for infections like Ruxo for viral and bacterial infections, or ibrutinib for bacterial and fungal infections, and so on. Comorbidity, of course, takes an impact on your decision. So you should avoid agents which have a toxicity in organs already damaged. So for instance, starting a CNI in a patient with renal insufficiency is obviously not a good idea. The history of applied agents. So avoid treatment options which already failed or have had unacceptable side effects. Or the other question is, did the patient flare when you stop an agent, which would somehow indicate an efficacy? The biology of the disease is where an overlap symptom present, then you would more use agents also used in acute graft-versus-host disease. Are there B cells and IgG levels, B cells present and IgG levels high, for instance, that would point towards a B cell involvement in the patient. The number of T and B cells overall, so if a patient doesn't have any T cells or rarely have T cells with very low numbers, you should avoid depletive strategies, and because the patient is already depleted, and organ pattern drives your decision somewhat. Compliance obviously has an impact, so avoid substance requiring the patient to be compliant if the patient has already been shown to be incompliant. And if the patient tends to stop oral medications, you need to find a way to provide the medication IV and listen to the patient's preference. If the patient indicates that he won't take your drug, it's very likely he doesn't. And then the next question is steroid refractory versus steroid dependent disease. So steroid refractory patients with inflammation need an anti-inflammatory agent other than steroids, for instance, ruxolitinib or tocilizumab or regulatory T cells. And the next question you need to ask, what is the distance to the transplant center and the availability of treatment? You can have a nice idea if the transplant center does not provided, then you shouldn't start it, obviously. And the next issue is approval status. So avoid financial toxicity to your patient or your department. Corticosteroids remain important. That's also one issue. So treatment without any steroids is hard to achieve in a patient with chronic graft-versus-host disease. And the next point is do not change more than 1 agent at once, and do not combine more than 3 agents at once, because it's then hard to tell which agent is working, and you usually add side effects and not efficacy in such situations. Fortunately, the list of agents now available for treatment of chronic graft-versus-host disease has been grown significantly through the last years. with ruxolitinib, ECP, mTOR inhibitor, calcineurin inhibitor, MMF, ibrutinib being most frequently used, but also methotrexate, although it has a long list of contraindication, may be an options for some patients. And imatinib could be also used in skin disease and mild and moderate BO. Rituximab has been applied, although you need to keep in mind that you deplete all B cells for at least 6 to 9 months, which increases the risk for infectious complications. The list is even longer. Newer substances like ixazomib or bortezomib or pomalidomide entered the field, and here you already see that some agents may be better for a specific situation than others. As for a pomalidomide, it has been shown that if you apply it early in the course of chronic graft-versus-host disease, you need to acknowledge a risk of an inflammatory flares, which does not happen late in chronic graft-versus-host disease. And also substances which are applied in rheumatology, like tocilizumab, already entered the clinic also in treatment of chronic graft-versus-host disease, although formal trials in chronic graft-versus-host disease are lacking. Abatacept, for instance, has been shown to have some activity in lung involvement of chronic graft-versus-host disease, but obviously needs to be explored in additional trials. How about supportive care? Infectious prophylaxis is crucial in those patients because most of the patients having treatment-related mortality do not die of chronic graft-versus-host disease, but of infections. So PCP prophylaxis is standard of care of any patient having chronic graft-versus-host disease. For pneumococcal prophylaxis, you need to apply either an active prophylaxis or standby antibiotics in compliant patients. HSV prophylaxis is especially important in agents known to increase the risk for viral reactivations like ruxolitinib, but MMF and calcineurin inhibitor do also increase the risk. Antifungal prophylaxis with a mold-active agent should be applied in situations where patient is either steroid refractory or has a history of fungal infection, or gets combination treatment with a relatively significant steroid dose. Vaccination is important. All patients having B cells and T cells detectable and then production of immunoglobulins should be vaccinated, independent of the activity of chronic graft-versus-host disease, although it's wise to wait until the chronic graft-versus-host is somewhat controlled to start with the vaccination. Bone density is an issue, so monitoring of bone density on an annual basis is important, and vitamin D supplementation should be applied to all patients with chronic graft-versus-host disease. Monitoring for infectious complications obviously depends on the degree of immunosuppression, so especially the combination of MMF and CNI or ruxolitinib would require a more intense monitoring, including viral reactivations compared to steroids alone. And one significant risk factor for infectious complications is additional neutropenia in a patient's getting intense immunosuppression. Screening of secondary malignancies in involved organs is very important. So skin and oral graft-versus-host disease exposes the patients to a significantly increased risk for late secondary malignancies. So you should keep that, and you should keep that in mind. And especially for oral graft-versus-host disease, it's hard to distinguish oral graft-versus-host disease from a secondary malignancy. So in most of the cases, only histology helps. And physiotherapy, an easy to apply options, which is frequently forgotten, is a very important issue in the long-term care of patients with chronic graft-versus-host disease, especially in patients with skin and fascia involvement. I'm coming to the end. While the number of treatment options is increasing, the individual pathway through the individual sequence of the agents applied in a specific patient remains a trial and error system. Any approval is likely to impact the sequence, so we can expect that some of the agents evaluated in randomized trials will enter clinic with approval, and that will obviously have an impact on the drug we use. Safety and evidence of efficacy are important drivers, so the agents being safe and tested within randomized trials are the ones you apply first, and those where the evidence is much smaller or there's a much higher risk for side effects should be applied later. Biomarker to predict the response are highly warranted but still lacking. The clinical decision should be based on the patient's risk profile, organ manifestations, course of the disease, comorbidities, and compliance, and developing individual treatment algorithms based on biology are the ultimate goal. With this, I want to stop, and I'm happy to answer your questions.